In this section, we're going to talk about what's new in MRI, specifically 7T imaging. My panel members are Dr. Antoneda, Dr. Ransohoff, and Dr. Lowe. And Dr. Lowe will lead us into talking about what's new in MRI 7 Tesla imaging. Mark?
Thanks, Alex. So what I want to talk about today are recent advances that have been made in ultra-high field MRI, in particular, as Alex said, 7 Tesla, with regard to understanding MS as a disease. Now, ultra-high field MRI has several advantages over clinical field strengths, which include field strengths up to 3 Tesla. And the advantages are the very high signal-noise ratio that you get at these high field strengths afford us to move to very high spatial resolutions and faster scan times. So we get better high-quality images in a shorter amount of time, which means more patient, less patient movement and comfort issues to confound the imaging. The disadvantages of ultra-high field MRI is that they're extremely expensive instruments to buy, making it very difficult to envision them anytime soon moving into a sort of a regional medical center market, probably for the time being limited to major academic centers. And another disadvantage is that there are serious safety issues at these high fields that need to be taken care of when performing these kind of studies. And it's interesting to note that there are at least 2 major MS treatment and research centers that have 7 Tesla scanners, notably the Cleveland Clinic and Johns Hopkins. What I want to demonstrate is that at 7 Tesla, we can do imaging that actually provides better understanding of MS as a disease. In particular, I'm going to focus on 3 areas across 4 recent publications. One that demonstrates that at 7 Tesla you get dramatically improved visualization of cortical lesions, of gray matter lesions, and another set of papers that demonstrate that we can actually have very good classification of MS lesions at 7 Tesla. And in addition, I'm going to show a study that shows that 7 Tesla allows us to examine in fine detail the morphology of MS lesions where you're almost getting pathological information in vivo. Now, the first study that I want to introduce here basically looked at different types of imaging that you can do at 7 Tesla, different types of contrast that can be generated with the imaging, and showed that with flare imaging, which you see in the top right image, you can actually clearly see a cortical lesion present in the image, and you also see it in the T2 weighted image in the bottom right. Whereas at 3 Tesla, there's been a lot of activity in what's called dual inversion recovery imaging, which is the top left image, and you see that in fact you see no evidence of a lesion there. So the conclusion of the study was that at the very high spatial resolution, cortical lesions are detectable at 7 Tesla, and that the T2 weighted sequences are recommended, in particular the 3D flare, because the CSF in the neighboring gyri is in the neighboring sulci is nulled out, and the 3-dimensional imaging technique permits us to go to very thin slices, which is critical for identifying these cortical lesions. The next aspect of 7 Tesla that I want to focus on is classification of lesions. There are a couple of studies that have been done. One demonstrated that by looking at very high resolution T2 weighted images, one can actually see, when comparing a patient with Sussach syndrome to a patient with multiple sclerosis, you can actually see evidence of the perivascular nature of the MS lesion vis-a-vis the Sussach syndrome lesions that are present in the data. This is an important capability considering the fact that Sussach syndrome and MS have overlapping symptomology and MRI presentation. And in addition, there's also a study that was done demonstrating the same thing with regard to neuromyelitis optica. In particular, the findings were that that what you see is a better definition of the relationship between the lesions and the deep venous system. In particular, it was demonstrated that MS plaques form around the microvasculature, and you can see this, a central small vein and in addition a hypointense rim on T2 star imaging. And these features are absent in both Susac syndrome and neuromyelitis optica. In addition, the previous study that I was showing that shows better visualization of cortical lesions allows you to differentiate based on gray matter count. Typically, MS will actually have a significant gray matter count or gray matter plaque involvement, whereas these other diseases seem to be almost entirely lacking gray matter involvement. Now, with regard to morphology, there's a study recently that was published basically demonstrating that although primary progressive MS and relapse remitting MS have very different clinical courses, the morphology of the lesions when examined at 7 Tesla are nearly identical, including the involvement of the perivascular features, including the hypointense rim that I talked about in the previous study, and in addition, gray matter lesion count involvement between the two. So despite the differences in the disease course, the primary progressive and relapse remitting lesions were seen to exhibit identical morphology. Thank you.
Thanks, Dr. Lowe, for your comments. I had a couple of follow-up questions for you. First of all, can you briefly tell us about differences in safety between 7 or higher field strength magnets and clinical magnets?
Well, there are two safety issues that come into play when you're talking about MRI. One is collision risk, which is when entering a stray field, when entering the stray field from the magnet, if any objects containing iron can be drawn to the magnet. This is a significantly increased risk at 7 Tesla because the force is doubled basically on any object that would be pulled into it. So one has to be very careful and vigilant at keeping anything that might be metallic away. And the other is from the scanning itself. Basically, a lot of electromagnetic radiation is being pumped into the patient, and the absorption goes as the fourth power of the magnetic field. And so the amount of absorption goes up dramatically at 7 Tesla, and one has to be very careful. Now, these scanners automatically monitor the amount of radiation that's deposited and will prevent you from passing safety thresholds. The problem that introduces is that it limits you in the type of imaging that you can do. So there are some types of imaging that deposit a lot of energy that you cannot do at 7 Tesla that you can do at lower field strengths.
The other question was, do you see a clinical utility of the 7T? You really alluded to it, but do you think we'll be using it clinically in the near future?
I do. I think that within the next few years, we will actually see FDA approval for clinical imaging at 7 Tesla. And the reason is that at the Cleveland Clinic, we are doing a lot of we're looking at a lot of diseases at 7 Tesla. And in a lot of cases, we're getting differential diagnosis versus the lower field strength scanning that's going on. And I think that evidence of that, being able to get differential information at 7 Tesla, will actually balance the risk to benefit issue with the FDA and get it approved.
Thanks, Dr. Lowe.
You're welcome. Thank you, Alex.
In this section, we'll discuss some basic sciences results. Our panel is Dr. Antoneda, Dr. Rich Ransohoff, Dr. Mark Lowe. Dr. Ransohoff will lead us through a discussion of MS Basic Sciences update. Richard.
Thank you very much, Alex. Today I've selected 3 from a large spectrum of recent research findings in multiple sclerosis and allied diseases. I've picked a sort of potpourri of recent papers, which I'd like to take you through. The first one is called Intrathecal Somatic Hypermutation of IgM in Multiple Sclerosis and Neuroinflammation. The paper comes from Klaus Dornmeyer and his colleagues at the University Hospital in Munich, Germany, and it was published in Brain just a couple of weeks ago. Complicated title, let's walk through it. Intrathecal means referring to the subarachnoid space. Somatic hypermutation is a process that occurs in B cells by which they start off with an antibody that doesn't bind very well to its target, and they revise that antibody over and over and over again to make it bind better. IgM, as you know, is the first antibody type which is made during infection. And you probably remember that if you get a positive IgM titer for a pathogen, then you got to get an IgG titer in follow-up to make sure that the pathogen was really there. So what did the investigators do? The background is this. More than 90% of MS patients have spinal fluid IgG oligoclonal bands. You've known that since medical school. About 40% of patients also have IgM oligoclonal bands, much less well known. Dornmeyer studied MS patients, other neurological disease, and healthy controls, and they focused on spinal fluid B cells. They took the IgG and IgM genes from B cells in the spinal fluid, and they sequenced them. And using that sequence information, they were able to show really quite surprisingly that IgM genes from spinal fluid, but not blood B cells, showed ongoing hypermutation, meaning that the IgMs, the B cells that were making IgM, were sharpening their antigen recognition within the central nervous system. This means that B cell clones are living in the CNS and are continuously refining their antigen recognition within the CNS. The result shows that these clones that live in the CNS are perfectly comfortable there, and this underlines that the central nervous system, particularly the subarachnoid space, is a relatively hospitable place for B cells to live. That means B cells can carry out all of their functions there. They can present antigen, they can make cytokines, and they can make antibodies, and they can participate, therefore, in the multiple sclerosis disease process. It helps us understand why therapies that target B cells, which are in development for MS, show a surprising amount of efficacy in the early trials. Let's move on now to another question. The title of this paper is Investigation of the KIR4.1 Potassium Channel as a Putative Antigen in Patients with Multiple Sclerosis, a Comparative Study. This comes from Vanda Lennon and her group at Mayo Clinic and was published in Lancet Neurology so recently that it is still online. I don't think it even has a formal, complete citation yet. The background question is this. Everything we know about the genetics, the pathology, and the treatment of MS tells us that this is an immune-mediated disease. But it leaves open the big question, what is the antigen in this disease? What is the target of the immune process? Recently, serum antibodies to this potassium channel, KIR4.1, were reported in the New England Journal of Medicine to be present in about 50% of patients using an assay called ELISA, which is a very sensitive but possibly low specificity type of immune assay. The same group then went on to report very recently in the Annals of Neurology that the KIR4.1 protein was removed from active MS lesions, suggesting that those antibodies that they found in the serum were part of an attack on the KIR4.1 protein within the brain, and making these antibodies potentially not only a marker for MS, but also part of the disease process. Lennon and her colleagues, who specialize in this type of research, wanted to investigate whether they could confirm these findings. So they studied the serum from well over 200 MS cases and a little over 200 controls. And these controls included people with inflammatory diseases, so they might have autoantibodies, but also people with non-MS neurological diseases. The first screen that they used was the same one used by the previous study. It was an ELISA assay, so that was the first screen. But it showed no difference between MS and controls, somewhat a surprising result. So then they used a much more specific, but equally sensitive assay called a cell-based assay, much harder to do. And they tested some of the serum, and they tested all of about 50 spinal fluids they had, and again showed no difference between MS and controls. Then they went into the MS tissue, and they showed that the MS brain tissue that was available to them showed no removal of KIR4.1 protein in immunohistochemistry of active MS lesions. So these results, I'm afraid, leave the status of KIR4.1 as an MS antigen up in the air. Now let's go to a disease where we do know the antigen. This is neuromyelitis optica. You've heard it mentioned before, and the name of this study is Efficacy of an anti-interleukin-6 receptor antibody, Tocilizumab, in neuromyelitis optica. It's a pilot study. Study comes from Takashi Yamamura, who's at the National Center of Neurology and Psychiatry in Tokyo, Japan, and it was published just this year in Neurology. As you know, NMO is associated with pathogenic autoantibodies to the aquaporin-4 water channel, which is present on the end feet of central nervous system astrocytes. Yamamura had previously shown that interleukin-6 promotes the production of this autoantibody by B cells in the blood. So he chose 7 patients with aquaporin-4 antibody positive NMO, and he selected these patients because they were not responding well to other therapies that had been used for NMO. So he treated these patients for a year with monthly injections, and the attack rate dropped from 2.9 per year to 0.4. Disability was reduced, fatigue was reduced, and interestingly, pain scores were also improved. And it's worth noting that interleukin-6 does play a role in the neurobiology of pain in completely different types of research. So this result provides class 4, since this was a completely unblinded, open-label trial. So it's class 4 evidence that in patients with NMO, tocilizumab can reduce the relapse rate, neuropathic pain, and fatigue. Thank you very much for your attention.
Thanks, Dr. Ransohoff. I had a question. I think Dr. Antoneda had a question for you. So just to be quite clear, do you think Dr. Lennon and her group's work on the KIR4.1 Potassium Channel as an antigen closes the book? Do you think there needs to be some other work on that? It was a lot of excitement when it came out, and
Yes, indeed.
Yeah.
It would be wonderful to have a clearly relevant, well-established, consistently proven MS antigen. No question about it. I don't think we can say that this closes the book. Both Lennon and Hemmer, the person who first reported the KIR4.1 findings, are experts in the application of this very difficult type of immunoassay. The technical characteristics of both studies were quite high, and both were rigorously peer-reviewed. The most I think we can say is it certainly puts the ball back in the court of those who argue that this is a relevant MS antigen. We need either to understand why the disparate findings occurred, and ultimately it does make it clear that one of these groups is going to be right.
Dan?
It sounds like, based on the data you presented, the immune system is quite active in the CNS compartment, based on work that several groups have done, including yourself. I wanted you to maybe reflect on how this is a radical change compared to our previous belief of the CNS as an immune privileged zone.
That's a really good question. Thanks a lot. And so was yours, I think. So we have to do a little bit of a history lesson to answer the question fully, and I'll make it a quick one. The concept of immune privilege of the central nervous system is 85 or so years old. And like anything that's been around that long, it's gotten a little bit creaky and somewhat complicated. If you reduce it to its basics, the concept of immune privilege means that an immune reaction cannot originate within the central nervous system if it is driven by T cells. And that remains true. What I think we've learned since then is that immune reactions that originate in the periphery, outside the central nervous system, driven by T cells, can extend into the CNS. That's why we have diseases like multiple sclerosis, and that's why we have effective host defense reflected by viral encephalitis or brain abscess. So there's no question an immune reaction can occur in the CNS. What I think is underlined by this new work on B cells in the CNS in particular is that the subarachnoid space and the spinal fluid are immunologically active areas. They're part of the CNS, but they remain sites where immune reactions can begin to propagate from the periphery into the CNS, kind of a way station in that sense. And also, I think we have learned over the past 30 years, starting with the work of Paul Knopf at Brown University, that B cell reactions within the CNS have a special place, let's say, and that B cell survival within the CNS is not only possible, but clearly occurs in many circumstances and may be very important for the pathogenesis of multiple sclerosis.
Thank you.
Thanks, Dr. Ransohoff. Welcome. I'm Alex Rae-Grant, Director of Education for the Mellen Center for Multiple Sclerosis. In this section, we're going to talk about best practices for busy clinicians. My panelists are Dr. Dan Antoneta, Dr. Mary Rensel, and Dr. Devon Conway. So I'll be presenting a few different abstracts from the recent consortium meeting and talking about their potential impact on clinical care. First of all is a poster, Disability Progression After Switching from Natalizumab to Fingolimod or Injectable Therapies, a NARCOMS analysis. And NARCOMS is a registry, patient registry, which is national, has 36,000 participating members. So this is looking at the NARCOMS database and compared change in patient-reported disability progression in patients who were staying on natalizumab or switching to a couple of other therapies after a minimum of 2 years of natalizumab use. So there are 547 NARCOMS participants who had more than 2 years of continuous natalizumab treatment, and they had more than 1 year of patient-determined disease steps, which is a validated measure. More than 400 stayed on natalizumab, 50 switched to fingolimod, and 71 switched to an injectable, either interferon beta form of that or glutathione acetate. And the results in the age, gender, and PDDS at the baseline were similar in the three groups. What was interesting is the mean PDDS increased, that is, got worse, in the switch groups, and this was a significant result. So obviously it's not a randomized trial, but it does make us think about the fact that there may be some risk in switching from natalizumab in terms of disease progression. Not definitive, but again, adds to our data looking at the change in disease when we make changes in our treatment. And I think we'll have to weigh the risks versus benefit of stopping natalizumab. Interestingly, another paper that was presented was about the high continuation rate and good disease control after switching from natalizumab to fingolimod. And I think this accentuates the fact that different data sources may give you somewhat different responses. So this was a Canadian group that presented their data from a collective which was ongoing management of fingolimod treatment. And data cutoff, there were 243 of 1,989 fingolimod treated patients who had prior natalizumab treatment. We don't know how long the natalizumab was taken before that. Most were females, the mean age was 42 years. And there were a number of reasons for discontinuing natalizumab, and those include adverse effects, antibody positivity for JC virus, lack of efficacy, infusion-related problems, and other adverse effects such as allergic reactions and shingles. Also concerns about the risk of progressive multifocal leukoencephalopathy in about 5%. So the data were collected, and during a 33-month observation period, most patients were able to continue on fingolimod, 83%. There were a few adverse reactions, and some people requested to be off the medicine or had lack of efficacy. Bottom line was oral fingolimod was associated with good tolerability in this study in patients discontinuing natalizumab. So we do have two studies really giving us a somewhat different texture of answer. And I think at least we need to be well aware that changing therapy may bring its own issues. So will this study influence your current practice? 0 being not change my practice, 100 being absolutely. I think the jury's still out, but I think we know that we need to cross over patients onto a new therapy pretty quickly and not have a washout period. And we need to tell our patients about the risk of relapses or disease progression during the time of changing. So quite a different study, but again, another useful study. It was a randomized controlled trial of physical activity and cognition in patients with MS. This was from Ralph Benedict's group in Buffalo. And it was a randomized trial design examining the effect of physical activity on cognitive processing speed in MS patients with mild to moderate disability. We know that processing speed is one of the more sensitive cognitive measures in this population. So 82 patients are randomized to an intervention or a waitlist control. The intervention was a theory-based program for increasing physical activity behavior delivered by the internet and one-on-one video chat sessions with a coach. And they measured self-reported physical activity and disability status and single-digit modality testing, which is a measure of processing speed. So the results showed actually a significant time by condition by disability group interaction on the single-digit modality test. That is, a greater increase in physical activity correlated well with a greater improvement in single-digit study. So it correlates with findings we've seen in Parkinson's disease and mild cognitive impairment patients that increased physical activity does have a positive effect on cognitive measures and really reinforces the value of counseling patients about physical activity in our clinics. So will the study influence current practice? Our practice is to actively counsel our patients about exercise in the MS Center. So for our practice, it wouldn't change it. But the question for you is, will it change your practice? Now, another interesting abstract was cardiac-related infusion-associated reactions in relapsing remitting patients with alemtuzumab treatment. And a number of different, alemtuzumab is approved in a number of countries and not in the United States at the present time. However, there is a plan for resubmission to the FDA for approval. And this is a relatively powerful medication which does inhibit MS activity quite significantly. But what the objective of this study was is to look at safety parameters and summarize cardiac-related infusion reactions. So the data showed that the incidence of any cardiac event was 12.5% among treated patients with alemtuzumab, most frequently tachycardia, bradycardia, and palpitations. Relatively rarely were there serious cardiac-related reactions in 0.5% or 8 patients. These included a bradycardia, atrial fibrillation, and sinus tachycardia. Occasionally there was hypotension and hypertension. All these events resolved with treatment, including one anaphylaxis event. So what's the point? With planning to resubmit to the FDA, our hope is that this medication may come to market in the United States. If it does, we need to have a great awareness of all the side effects from this treatment and be quite cognizant of all the potential problems that our patients could get into. We'll also probably need to know the patient's prior cardiac history prior to starting this medication. So will this study influence current practice? Again, we will be thinking about the monitoring that we use at the Mellen Center. You'll need to think about that yourself. So the question for you is, will this change your practice? Finally, I'm going to end with new AAN guidelines on medical marijuana, which had a lot of obvious press attention. Dr. Barb Koppel and a number of others wrote this. And the guideline did a systematic review of the literature on medical marijuana for a variety of conditions and indications. The reason I'm bringing this here is because multiple sclerosis figured prominently. And they made a number of recommendations with different levels of evidence about the use of these agents. The bottom line was that benefits did appear to be limited to symptoms, and so there really weren't objective signs of spasticity change as measured by a blinded clinician. We also saw some benefit in symptoms of chronic pain in MS. And the panel recommended these be used, and they're talking about cannabinoids as opposed to smoked marijuana, that these be used when standard treatments are ineffective. The recommendations were really limited to spray and pill forms. They really could not conclude anything about benefits of smoked marijuana. So I think in this case, one has to think about, again, the environment in your state, and one really must weigh side effects against benefit. For example, dizziness, altered cognition, depression. The lack of data on smoked marijuana is a concern and certainly should have clinicians avoiding suggesting smoked marijuana as a medical treatment. Will this study influence my practice? Again, will not change my practice or absolutely will change my practice. Thank you for your attention.
Thank you, Alex. Interesting studies that you pointed out. When you change medications or discuss with the patient about switching medications, do you feel like expectations of the patients plays a large role in how they feel on that new medication?
Yeah, thanks, Mary. I think it's true. And actually, with all of our treatment discussions, we need to set expectations for what we know the medicines do, because the patient's expectation may be quite different. I just saw a lady today, and she had changed medicine 5 times. The reason was none of them made her feel better. And so I sit with them and say, we're not going to make you feel better. We're hoping to help slow down something about disease measures when we talk about what those measures are. But you're right, setting expectations is critical in helping people understand what they're getting into.
Alex, you mentioned that alemtuzumab is being looked at by the FDA once again for approval in multiple sclerosis. And my question relates to how do you think we will have to monitor patients, either with baseline and follow-up testing, to maybe detect the potential side effects of that medication?
Thanks, Dan. I think that really the FDA will give us guidance on exactly what to do. I'm sure they will have a very standardized program for us to follow. We do know that we need to follow blood counts and platelet counts every couple of weeks prospectively for at least 2 years, potentially longer, for the risk of ITP in this population. We'll probably have to have some kind of screening for thyroid disease, for Graves' disease, and we may have to look at renal function in some ways, such as urinary proteins, to look for Goodpasture syndrome. So I think we will have to have a fairly robust set of markers, both prior to initiation to make sure there's no baseline disease, and then as treatment goes on. Thanks very much for participating in this program.